going to read a little bit because I want to get this right. But you're a lecturer in medical ethics and humanities at the Tel-Aviv University School of Medicine and bioethics and society at the Biotechnology department of the School of Engineers. And she's a medical anthropologist, and her research foci and background include, among other things, the subject of prenatal testing in the ultra-Orthodox Jewish community, social microdynamics in postnatal diagnosis, Down syndrome, and in her more recent work she considers both philosophical and anthropological understanding of the brain and its relation to conceptualization of the mind, and uses historical analysis to approach the ethical debate surrounding the practice of frontal lobotomy, and a cultural reading of the scientific and popular discourse on mirror neurons. So absolutely fascinating. In her latest published paper, she brings an extensive fieldwork in neuro-oncology in a neuro-oncology clinic to shed light on complex expert and lay constructions of brain tumours as objects of diagnosis. And I believe you're now working on two main projects: the cultural correlates of neuroanatomical research and brain localization, or how is culture mapped onto the brain, and based on participant observation in brain surgeries, the place of the mind in the operating room. And a couple of publications I'll draw your attention to in case you want to follow up. It's her 2010 The Alien Baby, Risk, Blame and Prenatal Indeterminacy, Health, Risk and Society, and a 2009 publication, Experts and Knowledge That Counts, a study into the world of brain cancer diagnosis in social science and medicine. Thank you.
Thank you. So, as you said in the beginning, so I arrived at 4 a.m., so I'm going to give a talk and comments on Annemarie's talk, which is, as much as I can possibly do, is just tell you stories from my fieldwork that I've just reconceptualized today in order to have links to Annemarie's presentation. Every time I come to the UK, I almost get run over by a car like twice a day at least, because I look at the wrong direction when I cross. It just happened to me this morning, so I kind of had a flashback into all my works that I've done and the kind of field works that I was involved in. And I cannot say that the analysis was, what does it have to do with the field of sociology of diagnosis? But I could try to do that, and that's what I'm going to try to do today. So I'm going to talk to you about just different stories, different scenes, and I'm going to do it very, very briefly, and will leave you and your own association fill in the gaps into exactly how this fits into the sociology of diagnosis. The only time that I actually use the wording sociology of diagnosis is about 2 years ago, but I think it was implicit in my work for at least a decade now. Okay, so I'm taking you to an internal medicine unit at an Israeli hospital in Tel Aviv, where a very new undertaking was happening, where you had Chinese medicine practitioners, acupuncture, working within the clinic, that is following doctors round and administrating treatment to patients that were lying in their bed, in the hospital bed. So I was there as an anthropologist, so I followed them around and looked at how everything happened, where the instruments were laid out in the hospital, and talked to the professionals. And you can think of the interesting conversation that would happen around the patient's bed, where you would have the professor coming in and talking about this and that diagnosis about the patient's problem. And 2 minutes afterward, when they leave, they would have the Chinese practitioner come and check the tongue and check the pulse for a very long time and talk about things that doctors absolutely had no understanding of or interest about, and then put the same page, the same report in the same file for the patient. And what I was also interested about was how these different kinds of worldview, of cosmologies, of medical models of disease, and all the things that we hear about and we know about from medical sociology come about within a field around a specific patient and very basic epistemologies that come to clash in microdynamics within a clinic. So this is scene one. Scene two, I am interested in how ultra-Orthodox Jewish women understand processes of prenatal screening and diagnosis, specifically of Down syndrome. Okay, so I was approached by a medical geneticist interested in really asking why don't those ultra-Orthodox ladies do more screening, okay? I, as an anthropologist, wasn't that interested in making them do more screening. I was just interested in the why. So what I did is hear the stories, and one of the interesting stories that I eventually got to write about was about implicit miracles. So one interesting reason about why not to have a diagnosis is this. If I am a righteous person and I pray to God about having a healthy child, okay, this is what I do, I'm religious, this is what I want to do. Now, say that I don't know if the child has a disease or has a disorder, has Down syndrome. I don't know either if he has it or if he doesn't. And I pray to God. Now, God can grant my wish and make that the child is born healthy, right? I wouldn't know that God made this miracle. That would be an implicit miracle. Now imagine how righteous I need to be in order for God to give me an explicit miracle. That is, for me to know that the child has this or that disease, and then to have it born healthy. So what is interesting here is that knowledge isn't always good, but in a very particular story, within a very particular narrative that makes sense within its own context. So it's not about being afraid of knowledge overall. You're talking about very educated people, okay? It's about understanding the context of where knowledge makes sense. So that's kind of also a little point. On the paper with the alien baby, I told a story that also had to do with these interviews that I had. And that's a story of a woman that had a screening, an ultra-Orthodox woman, that had a screening done for Down syndrome, and she was at high risk, relatively high risk, and she decided not to have a diagnostic testing. That is, she decided to have the baby anyway. Now, she could have given birth in the hospital, the baby would have Down syndrome. Oh, too bad, but that's her own decision. But what happened is that the baby was born, and to her word, he looked like an angel. And nobody could tell whether this baby had Down syndrome or not at its birth. Now, there was 3 days in the hospital with the nurses walking around, and the doctors, and herself, not knowing whether she gave birth to a Down syndrome child. And what I was interested in there is how uncertainty comes about in the clinic, both for the mother, not understanding the ontological status of the child, if you like, but the blame that is related not to the fact that she has given birth to a Down syndrome child, which she could have avoided if she had had an abortion before. That's not what she was blamed for. What she was blamed for was for bringing a child that is between categories, that we couldn't be sure how to treat and how to relate to this child. And that was really evident in the way she told the story. So there we have diagnosis that has to do with certainty, and yes, with placing things into categories. So it's a very kind of Mary Douglas straight away. Then I come back in the story of my life that flashes over to the study that I did. I spent 6 months at a neuro-oncology clinic where I followed patients, and I followed the doctors in their conference each week. and with the radiology conference, that is the doctor spending time with the radiologists looking at images, and then with the surgeons and so on. And that is really, and what I was interested in, of course, with the patients and the consultations, and what I was interested in here, and this is where really the sociology of diagnosis comes in, and this is where, of course, Annemarie is quoted and cited, and is how the diagnosis is being made from different viewpoint, and what happens when there are discrepancies between the understandings of the thing that we call a disease, which is here very clear thing, three-dimensional thing, which is the brain tumor. So there we have an interaction of categories. Now, one of my latest, well, that sounds like I do a lot, right? But I thought it's just, I'm now working on the issue of brain death. And I just wrote to Annemarie about that whether we can think about not how we define death, what is death, how we legalize the issue of when a person is dead, but whether we can talk about diagnosing death. And when does it comes up in the question of brain death. So when a person is brain dead, the person, which is different from a persistent vegetative state, right? The person that is brain dead cannot breathe on its own. It has to have a respirator attached. So what we say is that the person is effectively dead. The only thing that keeps him alive is the respirator, okay? But this person looks completely alive. The chest goes up and down, it's pinkish. So in terms of the lay epistemology, in terms of the social context within which we are, this person is completely alive, right? He's a patient. If the machine goes beep, beep, then the nurses rush in and treat him. And on the other hand, people say that this person is dead and organs can be taken in order to save somebody else's life. So what happens in the process of defining this person as dead? What are the authoritative tools that will convince us that this person is dead? Okay? This is very important in Israel, where ultra-Orthodox and religious side disagree on the current definition of brain death, because death for them should be based on a cardiac criteria for death, and, well, the medical model speaks of something else. Two last things, which are really, really the current, and I'm picking your brain here. Exceptional patients are patients that have been diagnosed with a life-threatening disease and are within the 5% abnormal survival rate. That is, if you have pancreas cancer and you're still alive 5 years later, you're within the 5%. And these 5% are not well explained. So you've been given a prognosis that you're supposed to be dead, usually 2-3 months, and you're still alive 10 years afterward. So the person that I'm working with, kind of a cooperation, where he's interested in knowing whether they're doing anything particular to make them still keep being alive. I'm interested whether in how the diagnosis and prognosis in this case, which is critical, has changed the narrative of their life, of their life story, really. They're alive after death, so to say. So this is another point where I'm really considering the issues of the sociology of diagnosis. So that's just to show how this can be related to so many other.
Thank you very much. That's added richness to richness.